Thanks very much for inviting me to come and talk to you this morning. I'm going to be talking to you about NatSSIPS. Some of you may be familiar with what that means. Many of you may not be, but hopefully I'll take you through a little bit of a background as to what NatSSIPS is all about, and bring that into the context of actually your sort of day-to-day work, really, and whether that's in theatres or in other environments. And my role, I'm recently retired, now back a day a week with the quality and patient safety team, and as well as offering the role as a human factors advisor, I'm the lead for this NatSSIPS work within the trust. So you probably get to see and hear from me a little bit more in this context in the coming months ahead. So what I'm going to try and do during the next 20-25 minutes, give you a bit of background, talk to you about what NatSSIPS 2 is about, which is the current version, and how the CPOC, the Centre for Perioperative Care, has been involved in formulating those, and then think a little bit more about what this is going to look like at NUH, and where maybe in particular it might sort of touch on the work that you do in your day-to-day work within different areas of clinical practice. And hopefully I'll sort of get to the point of thinking about with you about how you can get involved in this work, and how that might be either through sort of team-based engagement with change and improvement, or through personal involvement if you want to develop some skills around human factors and quality improvement, etc. I'll just touch on the very end about the fact that there is a Never Events consultation going on, and that hopefully will come back to you as a service, just to make sure that you've had a look at that and offered your opinions, because as a trust we need to respond to that in due course. So a little bit of background then. Quite a few years ago, some of you may have been around, there was quite a bit of consternation going on around safety of surgery, both nationally and globally, and some documents were published, in particular from the World Health Organization amongst others, around the concept of safe surgery, and safe surgery saves lives, quite a big campaign. And that was the sort of precursor really to the introduction at scale around surgical safety checklists. And those of you that were around when those were brought in will remember the joy of conducting those exercises and bringing them into our day-to-day practice. And I think a lot of lessons were learned around then about actually implementing changes in practice like this. But for many of us now working in a theatre environment, of course, the sort of safe surgery checklist, or its current version of it, is part of our bread and butter. But that's not true for other areas in the organisation, which I'll come on to. Obviously, this was being introduced in parallel with work at Department of Health level, or NHS England as it is now, around never events and never event policy. There were certainly many publications, both in the literature but also in the more popular press, around use of checklists. And Atul Gawande was one author who was really quite instrumental globally in a lot of this work. But also, of course, it also caught the attention of, the Daily Mail and others, about the fact that whilst we'd identified a list of never events, the majority of which were related to surgical or theatre-based practice, there seemed to be quite a lot of difficulty with improving the rates at which these were occurring, and that was up and down the country as well as in different areas of practice. So this was really quite an area that was vexing both professional practice as well as the public and the politicians. A task force was created in the early 2010s under the auspices mainly of the Surgical Safety Task Force, and this was where NatSSIPS, as it was sort of born, looking at really how to revise the use of checklists and think about what that might look like in practice, and to link it in with never events. And you can see that the frequency of never events at that stage was counted as one of the key measures of success with trying to improve quality of care, which, as is probably obvious to many people, that was not necessarily a winning formula. Various publications were coming out, both from those involved in safety science and organizational psychology around issues with checklists and how they're implemented. And of course, there was the article by Moppet and Moppet in Anaesthesia around 2016, which also really highlighted the fact that maybe counting never events was not a great strategy for really helping us identify the quality of care that was being delivered. Important for patients, yes, obviously, but as a service, rather more, we needed something more nuanced. 2019, then we saw the birth of the Centre for Perioperative Care, hosted by the Royal College of Anaesthetists, but actually very much a multidisciplinary approach that looked more broadly at the perioperative care pathway, within which obviously the delivery of surgical intervention or other forms of intervention would sit. The CPOP had much more explicit engagement of patients and lay representatives and other groups, and they really helped drive forward, or host at least, discussions to revise these national standards. And in the last 12 months, we've seen a new version of the national standards now being published, which have taken on a broader view, a more systems-based view of care, of safety and quality of care in the perioperative setting, but also much more broadly than that, as I'll show you. And actually, it acknowledged the fact that actually a checklist as such was not a one-size-fits-all, but actually something that needs to be generated and used in context and appropriately designed for that purpose. So actually it needs to involve the people who are going to be using it in helping design it, implement it, and then check it's working. So this publication was then also much more explicit about extending the reach of these standards beyond surgical care and perioperative care, but into other areas of care. And you can see that actually this is rather more extensive than previously might have been the case when looking at use of checklists and use of standards to deliver safe care when conducting an invasive procedure. We can see that we've now very much more explicitly gone into the worlds of interventional radiology, of hematology, of oncology, of endoscopy, etc., etc., etc. So you can see that actually there are groups there who may be much less familiar with the journey that we've all been on, if you've been involved in theatre-based practice over the past 10, 12 years. So these standards now have extended some of these sequential steps, and actually you can see that there's more explicit attention to actually understanding the pathway through which a patient will proceed in terms of from the point of view of obtaining consent, verifying procedures through the theatre journey. Let's call it the theatre journey, or the journey around having a procedure performed, through to actually then reviewing that practice at the end within a debrief. And we know that some of these things are part of our practice now. Some of them have been a little bit more tricky to embed in how we conduct our work, but this is a good opportunity for us to take stock of that. And I saw Jenny Weller speaking earlier. Obviously, this is where actually quite a lot of the qualities of team-based practice and team effectiveness will really sit, to help actually make best use of tools such as this to actually improve the quality of care that we are providing. NatSSIPS 2 also now features a much stronger focus on organisational support, organisational standards for the way in which we work. And actually, this is much more attentive to thinking about design of work, understanding work as done. So the fact that actually when we come to work, it's not the same day every day. There's always things that are going to vary. And the way in which teams really show their value is by being able to adapt and cope with those things. Now, some of those adaptations are going to be inevitable. We deliver complex work under constrained conditions, but some of those adaptations may be unnecessary if we can think and implement aspects of preparation for theatre, preparation for surgery, etc. If we can get more upstream and actually become more consistent and more reliable in how that is done. So this is what is meant by taking a broader systems view. What are we doing at NUH then? Well, the approach we've been asked to do, and which I shall be taking the lead on, is thinking about actually how do we put in place some organisational structure for this, and how do we then link with clinical services specialties to really embed this and actually understand the best way to embed this in practice. So there is an oversight group. That oversight group has been formed. We're just going to get it up into a better sort of pattern or cadence of meeting now. We've held back a little bit over the winter, and with various industrial action, etc., it's been quite difficult to find time and space for this, but now's the time for us to get on with this. So this is providing the oversight from the organisation and actually thinking about some of the broader issues which might need to be addressed through different avenues, which are perhaps above and beyond within the remit of individual teams. The next bit of work really is for us to properly understand and scope what current practice looks like. And you'll see that there's a couple of sub-points to point number 2 there, because I think there will be areas of good practice already across theatres, across other settings. And I think we're very keen not to disrupt that, but to actually make sure we learn from that and think about, well, what actually has helped embed that and actually ensure that it is performed and undertaken consistently. Many times I suspect we'll find areas where there's variation in how we conduct the theatre team briefing, how we conduct the use of whatever checklist we have in place, how we prepare for and then deliver the care in a consistent way. And that's where we probably see teams often working quite hard to actually adapt and cope with the fact that things haven't been quite sorted out properly. And thirdly, I know that we'll be going into areas, clinical settings, where some of these standards are a completely alien language, and it's taken us back 10 years to where we were before checklists even were a part of our work. And so here we're going to have to actually take a different approach to introducing areas of practice to how they might improve both the safety, the quality, the reliability of practice around performance of invasive procedures. You might think areas such as the emergency department, on the wards, maybe in an endoscopy and in clinics, etc. So there's going to be some work on some educational resources around this, which I shall touch on in a second. And then I think it's really important that we look at how we embed and actually establish patterns of learning from practice and day-to-day practice, and not just learning from harm or events where they've gone wrong, but really thinking about understanding how we practice day to day and become more consistent to get things right, because I think that happens a lot more often. So what are we going to do? Well, we want to set up some workshops, some opportunities to come and have conversations with different clinical service groups to think about perhaps coming to observe practice and to understand what that looks like, think about what the term team means to different people in different contexts, looking at what is good practice, where the frustrations, starting to have conversations with you in the context of care that actually help you identify, well, what are some of the performance influencing factors around you day to day that either both help good practice or potentially hinder it? Because I think understanding and scoping what that work looks like is very important. that is where I think we can link that in then to what educational training might we need to try and help improve the way in which we work in teams. I know there was a bit of dialogue earlier about teams with Jenny Weller and colleagues in the chat, but actually it is true that actually at a team level, teams are the expert providers of care. And actually, we just need to help recognise and amplify that and actually make that more consistent and more reliable. There's a bit of education and training to do in the background around team working and around human factors and systems thinking, which we'll come on to. But actually, I think the real secret of success for this is actually close to or at the point of care and how that is planned, and then how we then reflect or debrief that. So systems thinking, I'll get my little jibe in here about human factors. Systems thinking, human factors is more than how we work in teams and how if we get on with each other. It's really quite a rigorous approach to understanding the work that we're doing and how that is influenced by our interaction with things like tools and technologies, the tasks we're doing, the environments in which we work, how we organise our work on shifts, etc., etc. So it is a rather broader view than actually understanding in the moment at the point of care. And the outcomes from that model actually are both true for the way in which the service or the theatres or the system performs. The outcomes of that are also true for our well-being within teams and as individuals. So it's very, very important that it is bimodal in terms of the outcomes that can be achieved there, both for the service, for patients, and for us as staff. There are opportunities for people to engage and support some of this work, both in terms of enhancing their own training for trainees, I think, but also in terms of those of you with some responsibilities towards the management and leadership of a service, about understanding how we do that through observation of practice, designing improvement work, designing systems redesign about how we organise our work. There are opportunities there for us to work with you to try and put some of those methods into practice. And I think the final part for me is obviously this does link back to safety. The NatSSIPS staff and my role is embedded in the quality and safety team. So there is a strong focus on safety as one of the outcomes. And actually you can see that there's a new approach a new framework being brought in around how we seek to analyze harm events or where things have not gone to plan and create learning from that. This is not the talk to go into that in depth, but this is happening in the background. So all the systems that we've got are being altered. And I think this is really important for us, not just because actually that framework's changing in the background, but in terms of your day-to-day practice, just thinking about how do we learn from the work and from the care that we're providing. A traditional model has always been that system, that safety one approach of learning in retrospect. So, waiting for the car crash and then going off and thinking about it and thinking, oh God, we'll have to analyze that in a lot of depth to work out how it happened. But of course, actually, most of the time we get it right. So actually, yes, this is important, but I think we need to emphasize that there's much more for us to learn from day-to-day work and from understanding how we adapt and deal with all of the variations, the challenges that come about. And actually, how do we try to improve that so that the amount of work being done by teams and by individuals in teams to do these adaptations, we can actually just gradually tune that down by being better prepared and having some reliability, some standardization upstream, so that actually then the teams, when they're actually in more complex or tricky situations, have probably got better capacity to cope with it. And over time, we are not wearing people out and burning them out from having to do these adaptations all of the time for stuff which quite honestly shouldn't be needed to do that. So there's a lot for us to think about how we learn and improve prospectively. And I think this is where our sort of systems thinking and understanding how we recognise and manage risks and harm or hazards in our day-to-day practice. Just make that a little bit more explicit, make that a little bit more consistent, and that would build into how teams can consider proactively some of the situations that they're getting into at their day at work, or with a case that's in particular in front of them, or even in those ad hoc moments having to respond to things that are tricky and have not been planned, so down in ED, down in other environments. But let's be more prospective about how we prepare and learn about those, so that we can be more consistent in some of the ways in which we plan for that, the way in which we rehearse for it, and then deliver care. Obviously, I'm going to get a slide in about simulation somewhere. So there's a lot of work in the literature now nationally going on. I think there are programs in theatres with Miles and others around in situ simulation, but I think there are opportunities where we can also look at this not in the day-to-day work setting, but also in a separate in a classroom or in another environment, just to think about how do we understand the way in which we work, how do we think about opportunities to introduce different ways of working or improve practice and processes in a way that will actually enhance clinical pathways, care delivery in the moment, care delivery over a period of time, and really help us improve outcomes for patients. So I've gone through quite a lot there. This is the final slide. I think there'll be a chance for questions, and I might be able to answer some of them, I don't know. But actually, the one thing I put up on this slide, which I've not really touched on, is that I commented about never events earlier. There is a consultation going on nationally around never events, and actually, what should be the next step with evolving the use of or the identification of never events. And I think when you look at safety and safety in practice, especially in complex working environments such as theatres or interventional radiology or the emergency department, what you realise is that a lot of the barriers which actually are we create to try and prevent harm, a lot of those rely on vigilance, team working, people working at the best of their abilities on every given day. But we know that actually that's not a given. So a lot of the sort of high reliability safety industries really focus on having some barriers to prevent an untoward consequence, which are really quite hard and very difficult to get around. We think that actually for a lot of the never events that are probably influencing surgical or perioperative care or invasive procedures, have not necessarily got those hard barriers. There's a slight over-reliance on individuals and teams and human behavior and human capabilities. And I think there's work to be done here about actually how we improve the capacity for people to do that, which we do, but understand where and how some performance influencing factors might overwhelm it, so that at least you as individuals and teams can be more aware of when those circumstances are in front of you. But the never events consultation is very much around redrafting how and what that will look like. And I think it may be that that becomes less of a measure that we're relying on or having to use, but only if we can actually build in better measures and better ways of teams and clinical leaders engaging in improvement and redesigning their practice. So that's going on. I'll contact Chris and others about actually anaesthetics having a say in that, but we need to respond, and I think the response time is in a couple of weeks' time.